Dr. Faisal, we are starting your case. Bismillahirrahmanirrahim. And I will be giving you total 3 to 4 minutes to prepare your case. And once you
Okay.
have prepared, do let me know. And you
O-
will be allocated total 15 minutes with your patient.
So the consultation will be done in the new system, right? For 15 minutes.
Exactly a new pattern, PACES 23.
Okay.
This is your case. Have a look, then get back to me. And anytime, if you need any clinical signs, you need any evidence of clinical signs, you can ask me for the pictures. They will be shared to you.
Okay.
Take your time. Okay, are you ready for your case?
Okay, doctor.
Okay, you have total 14 minutes with your patient for this clinical consultation, and then it will be followed by 5 minutes of Viva. Okay,
Okay.
so I am giving you timer, and your time starts now.
Okay. Hello, I am Dr. Faisal, one of the PACES candidate here today. May I confirm your identity? Are you Mr. X and 56-year-old?
I am Mr. Khan, and I am 56 years of age.
Okay. So, Mr. Khan, I just came here to know that you are having some problem. Would you please tell me in your words what brings you here today?
I was sitting at the home, and suddenly I got vomiting, and it was full of blood.
Okay, so sorry to hear that. Okay, so is this the first time you are having this problem or any
This
similar
is
history of?
very first time that I am getting it.
Okay, so was it start suddenly or gradually?
It was quite sudden in onset.
Okay, and is there any previous episode of vomiting?
Mm, what exactly do you want to ask?
I mean, you said you vomit and blood, right? But before
Yes.
you have any history of vomiting, recurrent vomiting?
No, no.
Okay. So, could you please tell me now what about the current condition of your, vomiting? Is it increasing or is it remain the same?
I got only 2 episodes.
Only 2 episodes. Now there is after that there is no vomiting, right? Am I
No.
right? Okay. Oh, and you mentioned it's all blood. Is this mixed with food or anything else?
Yes, it was mixed with the food.
Okay. And have you noticed is the undigested food particles or digested food particles?
I am not sure.
Okay. So when this episode happened exactly?
It was quite sudden. I was just reading the newspaper and suddenly I felt like I'm about to vomit out. I was going to washroom, rushing there, and there was a frank blood there in my vomitus.
Okay. So, so may I know, do you have any, other than vomiting, do you have any other associated symptoms? Like,
Like, what do you want to ask?
do you have any tummy pain?
No,
And tummy distension?
no.
Yellow discoloration of eye?
Yes, but it is not current. Might be it was happening to me, if I am not wrong, for a couple of days, 1 year back.
1 year back, you had a yellow discoloration of your eye, right?
Yes,
Currently, you cannot notice, is there any yellow discoloration or not? Am I correct?
you're right.
Okay. So do you, how about your bowel movement?
What exactly do you want to ask?
Do you have loose motion?
No loose motion, but I was going to toilet in your hospital and I was just excreting out frank blood.
Okay. And when did this happen?
Might be I think about just half an hour back.
Half an hour back. Is it fresh? It is a bright red blood or dark blood?
Darkish, blackish, darkish, and some was quite bright, but it was quite a reddened black.
Okay. Any history of similar condition in the past?
I don't know whether this is similar to this or not, but might be about 6 months back time. I was passing out quite dark, loose motions.
Okay, dark loose motion. Okay. So, what about your water work? Any changes,
What
amount, water work?
what exactly do you want to ask, doctor?
Urine pass
I am passing the urine normally.
normally. Is there any change in color,
No,
amount,
no,
any reddish urine or dark
no,
urine? Any fourthiness of
no,
urine?
no.
Okay. So, Mr. X, may I know, do you have any known medical condition that I must be aware of?
I have been diagnosed as a case of diabetes and ischemic heart disease when I was in my country back.
Okay. For how long you have been diagnosed with diabetics?
I was diabetic might be for the last 10 years.
10 years. So other than this, do you have any other long condition?
Yes, I got a heart attack, if I am not wrong, about 1 year back.
Okay. So what medication currently are you on for this condition?
I am taking something called metformin, 500 milligrams thrice daily. I am taking glimepiride, 2 milligrams in the morning. I am taking
Okay.
lisinopril, 10 milligrams at night. I am taking aspirin, 75 milligrams daily. I am
Okay.
taking clopidogrel, 75 milligrams daily.
Okay. Any other medications?
No.
Any over-the-counter medications?
Sometimes I am taking multivitamins. That's it.
Okay. That's it. Any recreational drugs?
Yes.
Which one? Recreational drugs?
I am taking cocaine.
Oh. Okay, cocaine. For how many times you, or how long you have been taking this?
I'm taking cocaine, if I'm not wrong, might be for the last 2 years.
Last 2 years. And how often you taking this?
I think not much often, might be after a couple of weeks, might be after 1 month.
Okay. So what you mentioned about the medication, is there any recent change in medications?
Before this episode, no.
Okay. And after this episode?
No.
Okay. Any recent change in dose in medication?
No.
Okay. Do you have any known family history? Any long-standing disease in your that
Yes.
run in your family?
My father, he has been diagnosed as a case of shrunken liver because of
Okay.
hepatitis C. My
Okay.
mother, she has been diagnosed as the case of peptic ulcer disease.
Okay.
My
Ah,
sister,
yeah.
she is having something called sores in the food pipe. Might be they were saying it as esophagitis. My
Okay.
cousin, he is having something called Osler Weber Down syndrome.
Where's the blood syndrome? Okay. So now may I ask you some more question? Okay.
Okay.
Have you noticed that you being pale than before?
Of course, I have not noticed yet.
But at the same time I want to examine you. Is it okay, all right, with you?
For sure.
I want to see the anemia.
So, right now, anemia is present.
Okay. How about your weight?
Sorry.
Weight. Have you lost your weight
Wait.
recently?
No.
Okay. Do you feel any feeling sick or getting sick or anorexia?
No.
Okay. Do you have any skin rash?
No.
Any skin changes or anything else? Do you have any
Yes,
you
I
said?
am having some skin changes. If you want to see, you can see.
Yeah.
Also, I am having some other skin changes also.
I like to see that too. Okay. Okay. Is it now regarding skin rash? Is it blanchable?
I was not experimenting it.
Okay. Is it painful?
No.
Is it itchy?
No.
Okay. When you is it get old when you exposed to sun or stress?
No.
For this skin condition, have you consulted anyone? You doctors, you JP, or anyone else?
No.
Okay. So may I, you said you have vomit once, okay, and you have one frank, yeah. Do you have any bleeding from any other orifice of your body, like nose
No.
or anything?
No.
Okay. So what I want to examine you. I want to examine you from the hand first for
Okay.
general inspection.
These are the
Nail.
hands.
Okay. I can see there's a clubbing. Okay. I want to see the palmar. Okay. Then I want to see for any spider navy or gynecomastia.
So this is the rash. You can assess it whether these are spider nevi or something else. And this is the chest of the patient.
Okay. And now I want to see the eye, as I know
You
that there
want
is a
to
any.
see the rash might be more closely. This is the picture of that rash more closely.
Okay. Thanks for that. Okay. Then I want to see, as I mentioned, then I want to see anemia. I know that anemia is present. I want to see for jaundice.
Jaundice is absent.
Okay, I want to see or examine the mouth cavity and lips.
You are shoving light in the mouth cavity, trying to look till the oropharynx, and there is no obvious finding in the oral cavity.
Okay, now I want to examine the tummy.
So you are examining the tummy of the patient. This is the tummy.
Yes. The tummy, okay. I want to palpate it and look for any organomegaly or ascites.
How do you want to palpate it?
I want to palpate if, sorry, I want to
Go ahead.
superficial palpation, deep palpation, then go for the liver palpation.
So you are doing a superficial palpation as well as deep palpation and killing at least your 20 seconds in this process, because in the real exam, it will take some time.
Okay.
We will wait for 20 seconds so that you should complete your superficial and deep palpation in the S-shaped fashion. And when you are palpating the patient, of course, you are looking at the patient face. And this is the blunder if you are not looking at the patient face and doing deep palpation.
During the palpation, I must ask the patient, do you have currently any pain at your tummy? If you have pain, please let me know.
So you are asking it in the middle, and examiner is just seeing your face, and the patient is saying, no, I am having no pain in the tummy, and you are left with 1 minute and 30 seconds from now. You have completed your superficial palpation as well as your deep palpation. No finding at all up till now.
Okay, I can see some engorged veins, so I want to see, the test. Is it for vertebral obstruction or CLD? I want to stress the
no need. Go ahead for further examination. Do not waste time.
Okay, next I want to perform the liver palpation.
So you are starting for the liver palpation. Yes. Starting from the right iliac fossa, doing one respiratory cycle ahead in each cycle, feeling the liver edge with the radial border of your index finger, going above. You are reaching till right cage, and you are not finding any liver edge there.
Okay. Now I'm going to look for, spleen.
You are palpating the spleen, starting from the right iliac fossa, going towards the left rib cage, moving ahead, pressing your hand in inspiration and keeping it steady in inspiration and pressing it in expiration. And you can see that there is splenomegaly almost 3 to 4 finger breadths below left rib cage. And this dull time is up.
Okay, it's dull. Then
just give me a second, please. Okay, so summarize your case for us.
Time is up.
Of course, time is up.
Oh my God. Okay, so patient is a gentleman. Is 56-year-old male, came with 2 episodes of vomiting with blood, mixed with blood. This is the first time he is having this one. He is known patient of diabetes, ischemic heart disease. He has history of MI, and he currently on some medication, including recreational drug, cocaine. He has significant family history of his father, liver disease. Okay, and patient has some alarming symptom like melena, anemia. On examination, I found the patient has clubbing, leukonychia, patient has spider nevi, anemia, there is a splenomegaly. So based on things, I think this gentleman suffering from chronic liver disease, decompensating chronic liver disease. And
What
the
is
bleeding
the
might be,
etiology of chronic liver disease in this patient?
it could be a hepatitis, or as patient has a history of cocaine, he might be IV drug user.
How he is taking or injecting the cocaine, whether he is sniffing or injecting.
Sorry, I forget to ask this question.
If he is injecting, whether he is doing needle sharing or not.
Yeah, this should be at that time.
His father is having chronic liver disease secondary to hepatitis C, whether he is living with the father or not.
Yeah. And his sister also, yeah, hemorrhagic telangiectasia.
What are your other differentials?
My first differential could be chronic liver disease, esophageal varices. After esophageal varices, chronic liver disease. Another could be hereditary hemorrhagic telangiectasia.
If this is the case of hereditary hemorrhagic telangiectasia, are you finding any red spots?
I found somebody I feel is spider navy, but not in his mouth.
If this is the case of hereditary hemorrhagic telangiectasia, do you think that the patient will be having only gut bleeding?
Yeah, there is a possibility.
Do you think that the overall picture of this patient do get fit in hereditary hemorrhagic telangiectasia?
No, it's as he has a family history. That's why I put in the list on the bottom of my list. But it's more likely to the chronic liver disease.
Examiner will not accept this. We need to take into account the case as a whole, not just a snapshot.
Okay.
Okay, any other differentials?
Any other, it could be peptic ulcer disease. As patient taking antiplatelet, but I didn't see any of the proton pump inhibitor.
What if I am saying that might be this patient is having a peptic ulcer disease with underlying decompensated liver disease?
Yeah,
Whether it is making some sense?
Yes. As patient taking aspirin, clopidogrel, but not any anti-ulcerant, there is a possibility.
Okay. So what were the consequences of hematemesis? This patient is having hematemesis. When exactly he was having hematemesis? After how many hours or days or weeks or months back?
He said he has 2 episodes of hematemesis.
When?
Okay.
How he is feeling after hematemesis? Okay. So can you please give us a detailed investigation plan for Mr. Khan? I'm not talking about the disease. I'm talking about investigation plan for Mr. Khan.
Okay. For that, we want to perform upper GIT endoscopy to confirm our diagnosis and to exclude the possibilities.
Will you immediately scope this patient?
Immediately, I just put the first what to do for the confirmation.
This patient is right now in your ER, lying on the bed. Right now, what you will do?
Okay, first I have to do some urgent workup like CBC, urinary output, urine renal function test, serum electrolytes. Okay.
Why you are bothered about renal function test? Do you have any logic behind?
patient has, I can see the BP is low, 100/60. Urea is increased. Might be patient suffer from some kidney insult.
Do you think that this urea is increased because of hematemesis? Might be because of kidney insult? What is the possibility?
Yeah, dehydration.
Okay. Any other investigations you want to perform?
Any other? Yeah, serum electrolytes. I also serum electrolytes. Then I want to perform a X-ray of the chest. And then I
Any
will
reasoning
ultrasound
behind?
To see any perforation or anything else happened or any obstruction.
Which sort of obstruction or perforation you are thinking in this patient, Mr. Khan?
Maybe there is the vesis melusi, vesis, the rupture of the esophagus can cause vomiting of the blood
Do
vomiting.
you think that this patient might be having memory waste here?
No, there could be possibility.
Okay. Any other investigations?
And then I want to perform the ultrasound of the abdomen. And then I want to exit from a endoscopy, upper GI endoscopy.
Exactly when you will perform endoscopy. Right now, you are working in a best gastroenterology unit of your country. When you will perform endoscopy in this patient?
First, as I can see, patient blood BP is low, pulse is high. I want to first conservatively manage this patient. After settle down, I will go for endoscopy. And by this time, I also send the blood workout.
Okay.
As long as patient is settled,
how you will manage this patient?
Okay. I want to form a multidisciplinary team, including a gut doctor, a gastroenterologist, gastroenterologist, and a diabetic doctor and heart doctor. Form a multidisciplinary team. Then treat according to the underlying cause. As patient is currently bleeding, the option would be to find out what the source of bleeding. If there is a rupture, esophageal vessel, something like that, then we can go for the band ligation with the help of gastroenterology.
Okay, so I am getting back to this case, and let me share this case with you people. Just give me a second. And Dr. Faisal, please keep your mic unmuted because other mics are muted so that you should communicate with me if my voice is getting low. Are you able to listen to me clearly? Hello? Dr. Faisal, anybody, please keep the mic unmuted because if the mic is muted, I will never be able to know whether my voice is clear. Dr. Faisal, please unmute your mic.
Unmute.
Please keep it unmuted, yes.
Okay.
So this is the case, and this case is not as straightforward as we are thinking. The main important things over there is that the patient is having 56 years of age and he is Mr. Khan, not Mr. X. A very common mistake in the PACES is to take the patient name wrongly and not judging exactly where you are sitting and what is your role. This is very important. Sometimes it is written in your scenario. Presented with upper GI bleeding and he has lost to follow up for his diabetes and ischemic heart disease. So what I am getting from this scenario that the patient is having upper GI bleed and is a known case of diabetes and ischemic heart disease. When they are giving me vital signs, the patient is tachycardic with high hypotension, and the DRE revealed that the patient is having frank, bright red blood. There are two possibilities. Might be the patient is bleeding very heavily from the upper gut, might be the tummy, or might be patient is also having associated lower GI bleed, hematochezia might be there. Urgent workup, which they are doing in the ER states that the patient is having old ischemic changes. So I should keep in mind if I am planning for any intervention or might be if I am deciding for any drugs out there. Patient is anemic and urea is moderately raised. So my task is to take the focused medical history of the patient, do relevant examination, address his concern, explain management plan to him. This is my task. First challenge in this case is that we are having limited time, really limited time. We are having only 15 minutes. In this 15 minutes, I need to take a history. I need to examine the patient. I need to address the concerns of the patient, and I need to explain the management plan in a very shortest possible way to my patient also. So let's decode this scenario and let's see exactly if such scenario is coming in your exam, how I will proceed. What is coming in my mind might be when I'm seeing this scenario, let's talk about possibilities. I am sitting outside examination hall. What is coming in my mind? Might be this is a bleeding because of warfarin. Who knows? Might be this is a bleeding secondarily to aspirin. Who knows? Might be this is a bleeding because of NASH-related cirrhosis leading to portal hypertension. Might be this is a case of hemochromatosis leading to diabetes mellitus. So these are the rough estimates or rough guesswork which I am anticipating before entering in my examination hall. So I will write it down on my paper, but I am not sticking to them, but just I am having a rough sketch about them. So we are going inside and I am seeing this patient. So our examination starts as I am seeing the patient. If you are not getting it, or it might be you are not guessing it, that this patient is turning darker, might be you're having some dark tinge on the face, it is important for you to politely and gently ask the patient, anybody told you that you're getting darker than before, or might be there is any changes in your color or tone? This is very important. And sometimes this diagnosis do omit or get missed if you are appearing in these countries like our Pakistan, India, Bangladesh, might be in Arab world. So this diagnosis sometimes get missed out. But you are easily picking it up when you are working in those countries in which the skin color is quite fair. So I'm seeing this patient, but I am not getting driven by the fact that I am dealing with CLD. This is a case of CLD, and I am going to tell my examiner, and remember, examiner will never accept my any differentials if I am not appropriately ruling them out, because there will be cross questioning. There will be questioning exactly if you are mentioning this diagnosis, how you can say that. So I should be very fine candidate in the PACES, and I should be playing very safe, because I know that there will be cross questioning on me when I will be putting forth my differential list. So I am starting this case, and I am starting with same OD para, because it's a known pain symptom. Onset, of course, it was sudden. I was reading a newspaper. Duration, it happened might be just 2 hours back. So this is a symptom which can be recurrent. So I'm stepping back and I'm thinking whether my symptom can be recurrent or not. Yes, this is a symptom which can be recurrent. So ever in the past you got such episode? No. Okay, so 2 hours back, I got 2 episodes of bleeding, blood in the vomitus, OD para. Progression, any other episodes after that? No. Associated symptoms I will be asking in the end, but before that, I will be asking a relieving factor and aggravating factor. Whether I'm taking something, whether I was vigorously coughing, whether I was just vomited before, might be I am dealing with Bore-Heave syndrome, that is through and through cut in the esophagus, rupture of esophagus, or might be just a mucosal tear, biliary tear. So he's asking, candidate is asking, I'm telling that this was the first episode with the blood. Prior to that, I was not having any normal vomiting. This question is really pertinent if you want to pick the case of Bore-Heave syndrome, might be biliary tear. Now, I was doing OD para, so I am at associated symptoms. So I am stepping back and asking myself exactly what can be associated with the vomiting, blood vomiting. So I am not going to the books. I'm just stepping back and I'm asking myself, what can be associated? First question, remember, whenever you are dealing with the bleeding, bleeding from any part of the body, might be hemoptysis, might be hematuria, might be bleeding PR, might be you are getting bleeding from the vomitus. So it is important for you to ask exactly, sir, ever you got any bleeding anywhere from the body, including submucosal bleed or mucosal bleed. This is very important. Okay. So if you're asking and the patient is saying that, yes, I was bleeding from the nose also, I was bleeding in the waterworks also, I was bleeding from the gut also, I was also coughing up of the blood, it means that I am not dealing with the local pathology of the gut. This is a big clue. It means that I am going out of the gut. But yes, if he's saying that I never got any bleeding previously, it means that I am dealing with a local pathology. Say, for example, hemoptysis, local pathology of lung. Say, for example, hematuria, local pathology of bladder or urethra. If I am dealing with blood in the vomitus, it means that I am dealing with the local pathology of GI tract. This is very important before I'm going toward anything. So I am getting a clue that my patient is having hematemesis. Now, it's important to ask other associated symptoms like how was the stools? And the patient is saying that I am having bright red blood in my stools also. Ultimately, I will be asking about the tummy pain. Who knows, might be I'm dealing with the peptic ulcer disease. Previous history of tummy pains, previous history of vomitings, previous history of nausea. I'm not talking about drug history right now because I know that if I am going in the track, time will come when I will touch the drug history. Right now, I'm not touching. You want to touch right now, you can touch. But my scheme is that I will touch it when I will be opening up the case of drug history or medication history. So then I am asking about might be dysphagia symptoms, whether your food is getting stuck anywhere or it is not, you are not able to let the food down in your tummy. So what can be associated with the hematemesis? I am ruling out and try to rule out everything possible. Might be I want to ask about coagulopathy. I will be interested in bruises. I will be asking about the bleeding, submucosal bleed, or might be something like that. So I am not getting any clue except that this patient is having hematemesis 2 episodes 2 hours back. Now this patient is having hematemesis and still I am not reaching anywhere and I am not getting any clue. So what can be the other associated symptoms with this hematemesis? Think, just try to dig it out. Might be my patient is dealing with chronic liver disease, decompensated one. So, okay, I will ask about any altered sensorium, any alteration in sleep pattern before, any jaundice before, any increase in the size of your breast before, any tummy distension or tummy pain before, any melena or black tarry stools before, any pedal edema before. So I am gathering the clue whether I am dealing with might be chronic liver disease or not. So what I am getting, if you're asking me this question, I would be telling you that, yes, doctor, I am having altered sensorium twice, and they were providing me with some medication. I was getting into senses, and I am getting enlargement in the breast, and also I am feeling that my feet are quite swollen now, and I was having previous history of melena. So one thing is for sure that right now my case is going towards chronic liver disease, which is complicated by portal hypertension. It means that I am showing to examiner, rather telling to examiner that, see, I am ruling out all associated differentials. I am not making my mind that this patient is only having vessel bleed. I am ruling out even the systemic causes by asking about other features. Now, this patient got bleeding. And after bleeding, what you are suspecting? Of course, this patient might be having some dizziness. Already the patient pulse is tachycardic. Patient is having BP which is just 100/60. So I should ask about dizziness. I should ask about any fall in the house before coming to the hospital. I will be asking about palpitation. I will be asking about shortness of breath, because I want to be a very safe doctor. I want to tell to my examiner that I am really interested not only in the etiology of my diagnosis, what is the cause of this diagnosis which I am giving you, but also I am bothered about the complication as well as association of that diagnosis. So I'm asking, and he will tell me that I'm having palpitations, I'm having dizziness might be, I'm having blackout might be. So it is important to note, because my case is something that the patient is having a massive bleeding. So I am stepping back. I'm taking some break, might be 5 seconds, 10 seconds. And if you feel shy that what examiner will think, just coin a non-specific question in front of the patient. Might be you are asking about the hobbies. And when the patient is telling you hobbies, process this information in your mind, in which direction your case is going. What I am getting a patient with the history of the diabetes, the ischemic heart disease, and the patient got an episode of jaundice, might be 1 year back, having breast enlargement, altered sensorium, history of tummy distension, pedal edema, and my patient got 2 episodes of melena in the past, right now presented to me with dehematemesis followed by tachycardia and dizziness. Diagnosis is clear. Diagnosis is in front of me. But again, things are still blurry. Still, I am confused exactly what is the etiology of portal hypertension in this patient. Even despite I am not touching the patient, I am not examining the patient, I am more focused on the history, and my examination will be there just to confirm or refute my top differentials. Dr. Faisal, my voice is clear?
Yes.
Okay, thank you. So getting back to this case, general questions. General questions are really very high yield, and they are the backbone in making differentials and diagnosis. General questions should be at the tip of all my students. What are the general questions? Number 1, fever. Number 2, lumps and bumps. Number 3, weight loss or weight gain. Do not ask about weight loss, rather. Ask about weight changes, any changes in your weight. Of course, if there is weight loss there, then you have to ask how you are getting to know it. Are you measuring it, or might be with the loosening of the clothes, and also whether it is intentional or unintentional. It is very important. So, fever, lumps and bumps, weight changes. 4th question is really high yield. Please remember it as such, because if you're not asking about that, you will miss multiple differentials. Sir, do you have any rash, spots, or pigmentation anywhere in the body? Because pigmentation has totally different meanings than the rash. Rash have the totally different meanings with the spots. Spots, you are ruling out Osler-Weber. Pigmentation, you are ruling out your hemochromatosis. Rash, you are ruling out any rash associated. Who knows, might be you're dealing with a pen. So these are 3 questions. 5th question, any bruises or bluish discoloration on your body. Coming back, joint pain, body aches, fatigue, sweatings, dizziness from standing from the sitting posture, diet and appetite. I'm again repeating, Number one, fevers, lumps and bumps, weight changes, any spots, pigmentations, or rash anywhere on your body, any bluish discolorations, joint pains, body pains, sweatings, weather preferences, diet and appetite. These are the really bullets. And somehow or other, they are helping you reaching a diagnosis. And what we are getting in this case, if you're asking me, no fevers, no lumps and bumps, no weight changes, cancer going out. At least going down the list, if not out. You're asking about pigmentation. Yes, I am getting pigmentation. My color is getting more darker than before. Second important finding. Third important finding, I am having bad fatigue, which you're not asking. I am not ready. I'm not liking to get out of the bed. Other general questions are, negative. So what I'm getting? Fatigue with joint pains in the knees with pigmentation. See, the diagnosis is in your hand. What I was deducing before starting my general questions. Patient, hematemesis, increased breast size, history of jaundice, abdominal distension, pedal edema, history of melena, with joint pains bilateral in the knees, with bad fatigue, with pigmentation. Case of hemochromatosis. But I need to rule out other associated things also. Who knows, might be this patient is not having a bleeding from the esophageal or gastric varices. Might be he's having peptic ulcer. Might be he is having some ANSID history before that. Might be he's taking large dose of aspirin, who knows. So I am keeping my mind open. And I am also be bothered about needle sharing in the end. I will be bothered about NASH also. He is diabetic. So I am keeping my eyes open to rule out other associated differentials. Do not make your mind. Yes, these are positive findings. That's good. But yes, I will keep my mind open for all these possibilities. Dr. Faisal, my voice is clear and loud?
Yes.
Good. So now it's time to jump towards the PALM. 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 What is PALM? P for past history, A for allergies, M for medication history. Past history. Your records tell me that you have been diagnosed with the case of diabetes and ischemic heart disease. Tell me the story. If the patient is diabetic, to make it a NASH, I need to know exactly whether this diabetes is complicated one or non-complicated one. If I am putting forth the differential of NASH in this patient, examiner will cross-question me, what is the evidence of NASH in this patient just based of diabetes? They will never accept it. So ask about history of stroke, angina, peripheral neuropathy, that is numbness tingling in your hand and feet, might be peripheral arterial disease, pain on walking, might be CKD, that is foamy urine, decrease or increase in waterworks. So I am showing indirectly that I am excluding that this diabetes is not complicated one. If this is complicated, NASH will also come. I need to rule it out. If it is non-complicated, still NASH might be there, but slightly down the list. How is the control of your sugars? The 3 monthly sugar levels. Candidates are usually in our courses missing asking the duration of diabetes. It is creating much difference if the patient is diabetic just for the last 3 months, or if the patient is diabetic for the last 30 years. So ask about duration. So ischemic heart disease, what happened? What they were doing with you? They were not doing anything, just giving me injection to resolve that clot. That's good. Good. Family history, you have to explore, and he is not telling you any family history. Might be hiding. Towards the social history, smoking. Sorry, Sajid loves tea. Your brother Sajid loves tea. Smoking, alcohol, job, illicit drug, driving, traveling. Smoking, how many sticks per day and for how long? Alcohol, how many units per week you're taking? Remember, sometimes they are not telling you units. They will give you, I am taking 2 large glass of white wine per week. I'm taking, say, for example, spirit might be thrice daily, a small glass. Thrice weekly might be. So you should know exactly how much alcohol is there in each type of units of alcohol are there in each type of beverage. Then job, of course, you're asking. Then illicit drugs. If the patient is taking illicit drugs, then which drug, number one? Number two, with which route? If this is IV, if he is taking IV drug, then you have to ask exactly whether he is sharing the needle or not. Do not make all the patients with IV drug abuse that they are having HIV, might be endocarditis. You need some evidence. Then the driving, ultimately traveling. Traveling history is also sometimes tricky. Exactly where he was traveling. I am least bothered about recent traveling history. I want a traveling history to correlate it with my condition. Some candidates are asking, sir, do you have any recent traveling history? Yes, I was traveling to, might be Malaysia 15 days back. Or patient symptoms started, might be 6 months back. So correlation, temporal relationship is very important with the traveling. So where exactly you were traveling? Which sort of tour it was? Leisure might be, a business might be, or might be it was a family tour. What was your activities over there? Where you were staying, whether you were using a bottled water or you were taking, might be the tap water, which sort of food you were taking. Any specific foods do have some links. Then any visit to caves, lakes, your friend Jadia, other infections are there. It is very important. Vaccinations you are completing or not. Prophylaxis, say for example, for malaria, you're completing or not. One thing I'm missing in your history, and this was really important one, so I should get back. When I was saying PALM, in the PALM, past history, then the allergies, the medication history. Medication history, this is my teaching experience that sometimes the diagnosis is hidden over there. And this is, I think, most weakest part of our candidates. So what is the appropriate way to take the medication history? This is really important. Number one, sir, show me your medication list. Number two, are you compliant with this list or not? Because if he's showing you a list of medication, there's no guarantee that he's taking it. Third question, are you taking any other medication beside this list? Might be he is using some home medication of the wife. And this scenario has appeared. He was taking the beta blocker of the wife, leading to exacerbation of asthma. Any over-the-counter medication, any herbal preparations you are taking. Then any recent start of any medication before the onset of your symptoms. Any recent stoppage of any medication before the onset of these symptoms. So I will be bothered even about the medication, which can lead not only to hematemesis, but also to chronic liver disease, because this story is starting years back. Any side effect of any medication you are taking, because you will be bothered about the interactions also. He is taking some medication who is leading to postural hypotension, say for example, alpha blocker for might be BPH, and you are giving him right now, or starting him right now on ACE inhibitors. What will happen? He will be on the ground with the postural hypotension. It's very important. These things are sometimes crucial in making a differential. So I have completed my history, and I will be stepping back to think exactly what I am missing. Okay, might be I am missing AKI, he was mentioning, ask about waterworks, ask about amount of waterworks, ask about any problem in your waterworks. Might be I am missing something called,
Impact
if
on life.
I want to exclude other differentials, might be itching history, might be I want to ask other causes of uh, chronic liver disease if they are pertinent to my case. Say, for example, patient is female, patient is in the childbearing age, history of itching might be PSC, BBC, autoimmune, might be some autoimmune condition. So I will be also thinking about autoimmune hepatitis, something like that. So it depends upon your scenario. So now I have completed my history and I will immediately jump towards the examination. Examination should start exactly what is the presenting complaint. If the presenting complaint is hematemesis, they have already done the DRE, digital direct examination for you. So ask about observation charts, current charts. Sir, I need observation charts. So what is in these charts? Might be tachycardia, hypotension. So you have to check for saturation, might be random blood sugar levels you want to check. You want to check perfusion, everything like that. Then you are going towards and you are examining the hands. What can be the specific finding which you can get in this patient?
Sorry, can you repeat the question, sir?
Sorry, I'm not asking, I'm just describing it. That what can be the examination finding which a candidate can get in this patient? Let's make a map, just make a picture, get out of the books. Forget about the books. Just make a paint. Just paint a picture exactly what I will suspect. I will be suspecting a patient might be having tachypnea, might be having postural hypotension, might be patient is having bad tachycardia, hypotension. And when I'm examining this patient, pulse rate will be higher and I will be getting number one, clubbing in the hands. Number two might be leukonychia because of hypoalbuminemia of the chronic liver disease because the liver is now compromised. Third thing might be I am getting spoon-shaped nails, cholinachia, because of iron deficiency anemia. When I am seeing the dorsum of the hand, might be I am getting something called bruises over there because of coagulopathy. Then I'm saying to patient, requesting the patient, can you please turn over your hands for me? I'm looking the palms. I think I should share the picture with you. Sorry. So this was the clubbing and leukonychia. This is the dupuytrenal contracture, as you can see, and sometimes it is very easy to miss it in your examination because you are not moving your thumb horizontally on the palm because in the fair skin color patient, especially when there is no palmar edema. This patient is right now having palmar edema. It is more obvious over there. But say, for example, if there's no palmar edema, this dupuytrenal contraction is getting easily missed in the exam because already the candidate is under catecholamine rush. So it is very important to move your hand horizontally on the palms. You will feel a ridge over there, which is connecting the finger with the palm, and this ridge is dupuytrenal contracture with the palmar edema. So I am going above what I am anticipating over there. Might be I am getting some needle marks. He might be injecting cocaine leading to hepatitis B or C. Might be I am getting phlebotomy marks over there, but the patient has not been diagnosed as the case of hemochromatosis. This was my duty to diagnose and to start the treatment. Might be I am getting bruises on the forearms because of coagulopathy. Going ahead, usually CLD patients do have some temporal wasting also. And this is also finding in your CLD that the hairline is situated, just posteriorly. It is not normal, exactly normal location. It is slightly posteriorly. And if you can see that this patient is having hairline, which is situated slightly posteriorly with temporal wasting, not very clear, but they do have some temporal wasting. Might be I am coming down in the eyes, I can get jaundice, might be anemia, might be this, I am seeing the discoloration of the face, this tan discoloration, and might be even I am getting parotid, bilateral parotid swelling, which is going more toward alcoholic liver disease, but can be present in normal chronic liver disease also. Then if I am going down, what I will be suspecting, this is really common in our exams, really common, really common. And I'm telling you that there are 80% chances that you will not tell finding to your examiner. Number one, the hairline is posteriorly situated. Number two, there's temporal wasting. Number three, you will also miss there's loss of body hairs in that patient. So these findings you should tell to examiner. So when I am coming down, what I am seeing a patient with this gynecomastia thing over there, and this is a common site to look for spider nevi at the upper back. Also, sometimes they're in the front, but they are on the upper back. And I was sharing this picture with her to show that there are multiple spider nevi. Ultimately, I can show also that this is a more close-up picture over there. Coming down, I will be interested in looking for the abdomen, and I am seeing the caput medusae over there, and I am examining the tummy. And what I am suspecting in examination, because the time is so short, I'm having no ample time to waste time in doing unnecessary stuff. I should be very focused. I am not talking about a proper GI examination because it is at least taking 6 minutes in our station 1. This is a focused examination, so I should be very focused. I will be going for liver palpation, splenic palpation. Remember that in hemochromatosis, these patients do sometimes have hepatomegaly also instead of shrunken liver because of deposition of the iron. And of course, I will be interested in checking for shifting dullness and the pedal edema. So this is my examination. Coming back, whether I have completed my examination, big no. Why? Number one, I am not examining the joints which are involved. Patient was telling me that I am having bilateral knee pain. I should examine or at least offer to my examiner, if the time is short, that I want to also complete my examination by checking for the knees. And what is the methodology to examine the joint? Just remember this: look, feel, move, look, feel, move, look, feel, move. Look for redness, look for swelling, look for deformity, feel for fluctuation, feel for fluctuation, feel for tenderness, feel for hotness. Then move. In the movement, again, there will be two things: passive movement, active movement. In the passive movement, you will move the patient knee or the joint and see towards his face to see if there's any pain, any stiffness, any restriction of the movement, and then the patient will be moving the joint. So you have to do that whenever you're examining the joint. Of course, this is not a case of examination of the joint, so I am omitting it. But yes, you should be putting it in your mind that you have to look, feel, move the joint. But whether I have still completed my examination, still big no. If I'm having the time, it's okay. If I'm having no time, just offer to examiner, to tell to examiner that I am bothered about the examination, to diagnose my underlying condition, because this case is a double-ended sword. At one place, they want you to diagnose exactly why this patient is having hematemesis. At the other end, they wanted you to diagnose exactly what is the cause of chronic liver disease in this patient. If they are telling you that this patient is having hemochromatosis presented with hematemesis, your task is now half. But they are not telling you, it means that I'm supposed to take the history as well as to examine underlying chronic liver disease also. So what I'm missing, if I'm running out of time, I will offer this to my examiner. So I want to complete my examination by, of course, checking for JVP, listening to S3 sound of cardiomyopathy, and checking for genitalia, because these patients do have hypogonadism also. At least offer this. Dr. Faisal, my voice is clear?
Yes.
Good. So hemochromatosis, before we embark on the journey of investigations and management, just have a snapshot exactly what we are dealing over there. Hemochromatosis is a condition or disease in which there is iron overload. Once for all, clarify in your mind that the gene involved is HFE gene. Do not confuse it with the mutation. The mutation name is C282Y mutation, in which they are replacing tyrosine for the cysteine at position 282. So the gene name is HFE gene, and the mutation name is number one C282Y, and the other is H63D, two mutations. Okay, so in with what happens that there is iron overload, and this iron overload is not only in the liver, but it is a systemic process going on, starting from your pituitary problem. That is, it can lead to hypopituitarism by the deposition of iron over there. Even it can lead to the problem with the pituitary gland. It can lead to sometime cardiomyopathy if it is getting deposited in the heart. Ultimately, it do deposit in the pancreas, leading to its destruction and the diabetes. So what are the features? Usually hepatomegaly, splenomegaly, but can have the shrunken liver also. You should keep in mind that they are having really highest risk for developing HCC, that is hepatocellular carcinoma, because we need to even screen for it when we are telling our investigation. And these patients do have cardiac arrhythmias also. Cardiomyopathy, everybody knows, but some people are confusing it. That might be it is just a cardiomyopathy. They do have arrhythmias also, with diabetes, with tan skin, with might be hypopituitarism, with something called hypogonadism. And remember, this hypogonadism can lead to amenorrhea in the female and impotence in the male, and it should be incorporated in our history by asking, sir, I need to ask you a private question, and I do ask this to a lot of my patients. Do you have any problem in your intimate relationship? Skeletal problems, three manifestation. They should be in your mind when you are giving a differential of knee pain. Number one, it can lead to osteoarthritis. Number two, it can lead to pseudogout. Number three, it can lead to chondrocalcinosis. These three things should be in your mind. This is just a snapshot. I'm going through very fastly. Multiple things are there to discuss hemochromatosis, but we are running out of time. I think it will be more than sufficient, at least at the PACES level. So now, how to examine this, how to investigate this patient, and how to manage this patient. Again, this require, remember that in the PACES, they are not right now checking your clinical knowledge. They know very well that you have a good clinical knowledge. You have already passed your MRCP part 1, part 2. Right now, they want to see exactly how well you can apply your knowledge on live patient or real patient. So this is clinical judgment now. It will be really a wrong way to tell to examiner that I am starting from upper GI endoscopy might be, or might be I am going for HFE gene mutation checking might be, because right now the problem is not hemochromatosis. Right now the challenge which this patient is posing in our ward is hypotension secondarily to hematemesis. So first look into it. So of course, I'm going towards CBC, ESR, CRP. I will be very interested in renal function test. The reason is very good. That might be patient is having AKI. I will be bothered about your liver function test. I will be bothered about serum albumin, PT-INR. Of course, these are the indirect clues that might be I'm dealing with towards the decompensation. Liver is not making clotting factors. Albumin is low. It means that this case is likely because of vessel bleed. This is indirect evidence because already INR is deranged, albumin is less, means that liver function is already compromised. LFTs can be normal sometime in chronic liver disease. You should keep it in mind. Then I will be interested in, of course, ultrasonography to look for liver cirrhosis. Might be I'm getting hepatomegaly with ascites, and I will be getting splenomegaly. I have other fancy tests also. Fibroscan might be. And might be if there's any confusion in the later on, not right now, HVPG testing can be done. We are checking for the portal pressure. Now it's time to come back to that particular investigation of upper GI bleed in which I can get falsely increased. This is very important. Falsely increased thrombocytes, platelet count. Platelet count are less in chronic liver disease because of splenomegaly, spleen is overactive. But because of this reactionary thrombocytosis, I might get increased platelet count with the same thing which I was mentioning in the scenario, that urea will be disproportionately high as linked to creatinine. Now, again, this is a catch point over there. The patient is having normal creatinine with increased urea. What are the possibility? One possibility which is coming in my mind is might be dehydration, volume depletion. Second thing is because of course, bleeding, which is leading to increased urea. Because if this is AKI, might be I am getting also derangement in the creatinine, and these can be the cross questioning in your viva examination. So before you are labeling this patient, Dr. Fassler was saying might be patient having AKI, I will be going more towards might be dehydration, volume depletion, or might be bleeding. Yes, if creatinine is also raised, then I will be thinking about other causes. Dr. Fassler, my voice is clear?
Yes, doctor.
Good. So now I need to complete my relative investigations also, but I will be telling to my examiner that I want to stabilize the patient, I want to manage the patient, but later on, when the patient has been managed, I will be going towards, of course, HFE gene mutation stacking. I will be going for ferritin levels. I will be going towards transferrin saturation. I might, if diagnosis is in question, very less time, I might go towards liver biopsy, and I will be interested in checking for echocardiography because I know very well these patients do have cardiomyopathy, along with checking for LH, FSH to rule out hypogonadism. And also I will be checking at least one scan of the knees also. So I have completed my investigation. I am not only investigating upper GI bleed, but also I am investigating other associated complications of not only chronic liver disease, but also hemochromatosis. This is exactly what examiner wants from you, because now there's a difference. Previously, the viva of this station 5 was only of 2 minutes. Right now, it is of 5 minutes. So they are expecting from you to tell them in detail about all associated investigation about the patient. Management is really straightforward. You have to stabilize the patient. You have to give crystalloids. We are avoiding something called plasma expanders. If we can manage this hypotension with the crystalloids, the best choice is normal saline, of course. We will be managing if there are high blood sugar levels, double bore cannula. We will be starting this patient on octreotide, and octreotide means the sandostatin 1, octreotide 1. No, I am not going towards terlipressin because it is contraindicated in ischemic heart disease. And that was the catch point when I was telling you that the patient is having ischemic heart disease. You should mention it. You have to stabilize the patient. Even if you are working in a best test center of GI, you have to stabilize the patient. Then you have to go for scope of the patient. Now, if the patient, this is really important to know in the case of GI bleed. Number one, you should note down the following points which I am about to tell you about GI bleed. Number one, in any GI bleed, upper or lower, variceal or non-variceal, there is no role of tranexaminic acid. If the patient is having GI bleed, the upper one, you have to scope this patient in 24 hours. If you are doing less than that, you are increasing the morbidity and mortality. You have to stabilize the patient first. If you are suspecting that the patient is having variceal bleed, you have to scope the patient in first 12 hours, preferably. If the patient is taking aspirin or any antiplatelets in upper or lower GI bleed, which is non-variceal, you will not stop this aspirin if they are giving it for secondary prophylaxis. If they are giving for primary prophylaxis, you can stop it. And you have to resume it immediately after hemostasis. If the patient is having vessel bleed and the patient is taking aspirin for secondary prophylaxis, like our patient is taking, then you have to stop the aspirin and take into board your cardiologist. Coming back, we need to manage this case as MDT. We need the approach from endocrinologists for diabetes, cardiologists for cardiomyopathy, and we need to manage underlying chronic liver disease also. Again, chronic liver disease management in this case will not be easy. At one point, you are managing hemochromatosis. At other point, you are managing chronic liver disease. For management of hemochromatosis, you need phlebotomy. You need to remove at least 1 unit of blood per week till your ferritin level is reaching at the level of 50 to 100 microgram per liter. It sometimes takes more than 2 years. Once it is reaching at the level of 50 to 100 microgram per liter, now you can reduce your phlebotomy, removal of the blood, might be to 3 months or 6 months. Remember, after 4 or 5 episodes of phlebotomy, you have to check hemoglobin as well as ferritin. If the patient is not following this procedure, might be patient is having heart failure, this is contraindicated, might be, you have to give chelation, usually by desfuroxamine, 2 grams at least 3 times a week. But this is second line. First line is phlebotomy. You need to manage diabetes as per protocols. You need to manage arthralgias as per protocols. You need to manage cardiomyopathy as per protocols. And also, you have to screen for development of hepatocellular carcinoma after every 6 monthly. And I think you people all know very well about the family screening of the siblings and the kids. One thing I am forgetting over there, and sometimes there's a cross questioning about that, and this is really important, about the correction of anemia. This patient is having right now the HB of, I think if I'm not wrong, 8.5 milligram per deciliter.
Yes.
Listen to me very clearly, please. In any type of GI bleed, upper or lower, variceal or non-variceal, you have to keep the HB between 7 and 9 in acute episode of GI bleed. 7 to 9, 7 to 9, 7 to 9, 7 to 9 milligram per deciliter. You will not overshoot it. You have to manage in between. And usually you can scope the patient above 6. If the patient is having ischemic heart disease, this range will change into 8 to 10, 8 to 10, 8 to 10. So normal person, 7 to 9. Examiner will ask you, will you transfuse or not? No, sir, I will not transfuse. Ischemic heart disease, 8 to 10. I hope this is clear now. Anybody wants to ask any questions or queries? Any questions, any queries, any confusion, any
doctor,
problems?
What happened if we infused, I mean, in this patient, hemoglobin is 8.4. So we do not need to infuse any blood, right?
We will not infuse any blood. Just
If
this fluid we have to give because the patient is tachycardic, having hypertension.
So how will you correct the hemoglobin?
After settlement of acute episode.
Okay.
Dr. Amir, please unmute.
Assalamu alaikum, sir.
Walaikum salam.
Sir, I want to ask, sir, the point regarding a patient on secondary prophylaxis with aspirin. You said in peptic ulcer disease, the secondary prophylaxis shouldn't be stopped after the acute episode has been resolved. And in the cases it's variceal bleed in the patient on secondary prophylaxis, we should stop aspirin afterwards, after the acute attack.
Yes.
So should we put a patient on some other antiplatelet like clopidogrel, or should we stop altogether for the rest of his life?
We will stop antiplatelets. We will take on board your cardiologist friend. Finish.
Thank you, sir. So thank you. So,
Dr. Mo, please unmute.
I want to know in this case, in this particular case, what is the direct cause for liver cirrhosis and portal hypertension and this esophageal varices? What's the cause here? This hemochromatosis or hepatitis C, or I'm confused for this in this case.
Of course, this is a clear case of hemochromatosis, and we are managing on that line.
Hemochromatosis?
Yes.
What is the clue here in this to be?
Number one, chronic liver disease. Number two, diabetes. Number three, tan skin. Number four, hypogonadism. Number five, bilateral knee pain.
Okay, thank you, sir. Thank you, sir. And he has no hepatitis C, and his father get infection.
Yes, of course, we need to screen for it, especially if he is coming from endemic areas and also if he's in touch with the DAT.
Okay, sir. Thank you, sir.
Dr. Faisal, please unmute.
Thank you very much, sir. Sir, as regards systemic inquiry, systemic examination is concerned, isn't it better to mention that patient has pallor instead of anemia? Because anemia is a lab diagnosis. So
you are right. If you are going in detail, of course, you are right that we should say that the patient is having pallor might be. Anemia is, of course, a laboratory diagnosis. You're right. Okay, so we are having one more case of communication skills. If anybody wants to have it, please use it in an option and I can give that case. This is open offer today. Anybody wants to do the case of clinical communication? This is a really high yield case. And this is according to PACES23 new pattern. Come forward, user in adoption, and I will give you that case. Any of my previous students, any new student, anybody need that case, please come forward. Or might be you can text me in a Zoom chat box. Anybody wants a case? Dr. Satinder, please unmute. Dr. Satinder, are you with me?
Hi, Dr. Salman.
Yes.
Just a minute.
Okay, are you ready?
Yeah.
So speak to me because sometimes your mic is not working properly. Is it clear?
Yeah. Is it clear from my side?
I think it's better, much better. Okay. Dr. Satinder, I am giving you a couple of minutes to prepare this case. And this is according to the latest pattern of the PACES, which is going to be implemented in the DIET 3. So you will be given almost 10 minutes with your patient, okay? And this case will not be followed by the cross-questioning by the examiner or the viva, because according to new pattern, there is a no viva at the end. So you will be judged, you will be marked just based on your communication.
Okay.
This is your case. Have a look, prepare it well, then get back to me. And Dr. Satinder, are you ready?
Just a minute, Dr. Okay. I'm ready, Dr. Salman.
Okay, so the son name is missing over there, so you can say might be Mr. Salman.
Okay, fine.
So you are having total 10 minutes with your patient, and I will prompt you at 8 minutes, and you will be marked just based on your performance and communication. The catch point over there is that this scenario is loaded with multiple information, and you should grasp it, should make a plan exactly how to communicate, then go ahead. So I am giving you timer, and your time starts now.
Okay. Hi, I am Dr. Satyendra. I'm one of the doctors here in this clinic, and we are looking after Mrs. Jia. Are you the son of Mr. Zia?
Yes, I am the same.
Okay. Could you please confirm your name? Yeah.
I am Mr. Salman.
Okay, Mr. Salman. I hope I didn't. You didn't have to wait very long before meeting me.
Okay, thank you for your concern.
Okay, so Mr. Salman, we are here to discuss about your father's condition today. Uh, how much do you know about your father's condition?
I am really not good. I just came over there from America yesterday, and I am seeing that the dad is not in senses. It is all my fault that I was ignoring the dad. I am seeing that he is forgetting a little things. Also, so much so, he was going outside, might be to get a bread, and he was forgetting way back to home yesterday. And he is not taking anything. He is unable to eat properly. Rather, I can say that he is not eating anything. I need your help, please. Exactly what's wrong with my dad?
I'm sorry to I'm sorry, Mr. Zia, Mr. Salman, your father has been having this condition, and you are feeling so sad about it. Uh, is there any particular reason that you are blaming everything on you?
Because I was not taking care of him, and nobody is telling me that your dad is in this condition. I think rather I am going in depression to see my dad in this position.
I see. Okay. I'll try my best to explain, Mr. Salman, regarding your father's condition. Okay, and your father came he came to us with the complaints of recurrent falls, and he was unable to take food, and
Speak
also
slightly louder.
he had problems with his memory. Uh,
Mm-hmm.
so our team has evaluated, and our team has diagnosed him with a condition called advanced dementia.
Mm-hmm.
In this condition, there is a there is degeneration in the brain.
How
Hello.
I will know what is a degeneration? I am a lecturer at the in the college.
Okay, so Mr. Salman, uh, uh, so it means that the brain is the function of the brain is deteriorating,
Mm-hmm.
and it is mainly related to his age.
Mm-hmm.
And with time, his memory is also uh, affected.
Mm-hmm.
uh, it also results in uh, decrease uh, it also affects his ability to take care of himself.
Mm-hmm.
He also forgets the 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 recent memory
This
where
is exactly what I am telling you everything, and you are repeating those information to me. I just need to know exactly what is the reason for this condition and how you will manage my dad.
okay. So Mr. Salman, so there it's very
Step back. You're getting confused. Step
yeah.
back. Take deep
Mhm.
breath in and out. Then
Okay.
reorganize yourself. Then go ahead.
Mhm. Okay, so Mr. Salman, with age, there are areas in the brain which are getting damaged,
Mm-hmm.
and those areas control the memory and
Mm-hmm.
the actions,
Mm-hmm.
and this results in the uh,
Mm-hmm. What do you think that what will be the future life of my dad? And
okay.
also, he is unable to take the food. I am really bothered. He is getting weaker day by day.
I'm sorry, Mr. Salman. This condition is a progressive condition, and with time, your father's condition may worsen. We will, yeah.
I was talking to my cousin, and he is gastroenterologist in Pakistan. He was telling me that might be you can try putting some tube in the tummy. Do you think that you can consider at least talk with your consultant about according to that? And he was might be mentioning two tubes, one from
Mhm.
the nose, other from the tummy.
Yeah. So yes, Mr. Salman, you are quite right. There are these methods which are available to allow him feed properly, in which there is a tube which can be inserted through his nose, and that can go into directly into his stomach, and that will be evaluated by the swallow team, and
I am not in hurry. You can talk with your consultant. Let me know. But I'm just asking your, your idea and what is your perception about that? If we can go ahead with putting the tube, is this a wise decision? Because at least it will improve his nutrition.
Yes, Doctor. Yes, Mr. Salman. That can be a decision, but that will be decided by the team which overlooks these things. This is a solo team which will study your father and will decide about the final decision. Okay, and there is another type of tube feeding which is directly put into the stomach by making a nick in the tummy, and is also one of the method. But what is the best method to for your father, that will be studied by the solo team. We will discuss it later on. Okay. So because your father has a tendency to fall, as of now, we will like to involve a specialist called occupational therapist. So occupational therapist may have a look at your home, where he is living today.
I don't know. I am leaving back to America. Might be after 15 days, because I am working as a lecturer over there. Who will take care of my dad?
Okay.
2 minutes from now.
Okay. So, Mr. Salman, so what we will do now, we will discuss it with the social worker to provide the care of package for your father. So somebody will be staying with your father to take care of him at his home. Will that be all right?
I don't know. I'm not known to your system. Might be this is right or wrong. I have my own decision. Do whatever you want to do to make my dad good.
Okay.
Is there any medication for this condition?
Okay. So, Mr. Salman, there are some medications available for this condition, but the but this will decision to initiate the medications will be decided in the multidisciplinary team meeting, where we will involve a specialist called brain doctor, and we will also involve the other specialists like.
Also, you must involve your gut doctor. Might be to put that tubing.
Yes, Dr. Salman. Yes, Mr. Salman, we will do that.
Okay.
Okay. Do you have any more concerns, Mr. Salman?
No concerns.
What I'll do now, I'll give you some information regarding the support groups which are available for this condition. Okay. I'll give you some leaflets regarding this condition, and you can study about that.
Time is up.
Okay.
Dr. Satinder, what has happened? Why getting confused? Was it a difficult case?
No.
Might be this is a common mistake made by multiple candidates, that they are not first making a roadmap at exactly how to do a particular case, and we need to follow the same pattern, the same skeleton of communication, but of course the information in each scenario is different. So let's start this scenario, and you will be marked just based on your communication, and according to new pattern there will be a no viva. So this is really a dangerous thing, because you will not be given any chance to tell to examiner that I was right or wrong or what I wanted to say to patient. So you will be marked just based on your communication with the patient. Sorry. So let's go ahead, and I was checking, might be I'm able to use this pen. Yes, that's a good thing. Just a second. So this is the scenario. Number one, elderly male, Mr. Zia, known case of depression, living alone, very important, has currently presented in ER with the history of recurrent fall. He is unable to take food properly, very important, and is having gradual worsening of the memory. A team has diagnosed as the case of advanced dementia, and my task is to talk with the son. The underlying things which I am underlining right now are really important because I need to focus more on them. Now, when you are starting like that. First, your introduction, patient introduction, or son's introduction. Hello, sir. Good morning. My name is Dr. Assam, one of the doctor in the clinic today. Am I speaking to Mr. Salman, the son of Mr. Zia, 85 years old patient? Yes, I am. Sir, I hope I am not keeping you waiting too long to see me. Okay? Okay. So now usually we are taking the consent before talking to other person, but what I believe is that the patient is not having the capacity right now. So I will be saying that I am over here to discuss about your dad's health condition and its management, and I will be more than happy to answer all your questions. So this is something called setting the agenda. Why you are meeting today? After setting the agenda that we are over here to discuss about the dad's health condition, we will be applying the ICE, ICE, idea, C for concern, E for explanation. So what you have been told so far about your dad's health condition, and this is really important, that the son is landing just yesterday from America to see the dad. It means that the things are slightly complex over there, and we should keep into account that exactly with whom I am talking and how much is the patient social support. Are you with me, Dr. Satinder?
Yes, yes.
So first, your introduction, patient introduction, setting the, establishing the rapport, setting the agenda, then applying the ICE, I for idea, what you have been told so far about that health condition, C for concern, any specific concerns, any specific expectations from our today's meeting, then is explanation. In explanation, my task is starting. Sir, you are very right that your dad is having forgetfulness, along with he is not taking the food properly. And let me tell you that he is a diagnosed case of depression and also having a recurrent history of the fall. Our team has thoroughly evaluated your dad, and we are coming up with the conclusion that your dad is having a condition called advanced dementia. Clear?
Yes.
Okay, good. So, don't bother by the medical term. This is a condition in which there is aging of the brain. Different part of the brain is getting aging. Because of that, the brain is not working properly.
Okay.
This disease is not curable, and I am so sorry to tell you that it is also progressive. So first you are telling pathophysiology, then you are telling prognosis, then you are telling clinical feature. This disease leads to memory problem, leads to problem in dealing with daily activities, daily challenges, and also can have speech, memory problem as well as eating problem. I am so sorry to tell you that ultimately patients do get bed bound. Sir, we are over here with you and your dad in this difficult time, and we will not let you people suffer. Clear?
Okay.
I can understand that this is not easy for you, and please do not blame yourself. This is a disease which is spontaneous. There's no fault at your part that you were not over there. If even you are over here, it will not change the pattern or change the progression of the disease. Sir, as I was telling you that this disease is progressive. Your dad really need social support. Might be in the future, he will not be able to carry out daily activities. Might be he is getting bed bound. Clear?
Yes.
So I need to ask you few questions if it is okay with you. Sir, you are not over here with your dad. Do you have any family member or any friend who might be who can take care of your dad? No. So now when he's saying no, we will provide with the social support. We will be talking with our social teams and see how we can help him in this regard. Might be we are managing him at the home, or might be we are shifting him in the nursing home. Is this clear?
Yes.
So I am going bit by bit. I'm going in the pieces. I am taking the hold of the scenario. I'm not missing anything because I know that there is a reason why they are writing all these details. Sir, your dad is also having depression. Have you ever felt that your dad ever tried to end up life? No. Also, we will assess this risk. If he is having such a risk, we will immediately admit him in the hospital under strict medical care and surveillance. So indirectly, you are telling to examiner that I know that we have to apply Mental Health Act. Clear?
Can you repeat this one again?
If the patient is suicidal, he needs medical care. He needs to be restricted in the hospital under Mental Health Act Section 5(2).
Okay.
Clear?
Yes.
So we are telling to him directly that if he is having any suicidal intention or ideation, I will be restricting him under Mental Health Act, and we will be giving proper psychological and psychiatric support.
Okay, so this point it was not mentioned. So still, shall we discuss this?
This is a hidden agenda. Depression is there. Whenever there is depression, you must talk about suicidal ideation or suicidal risk. And if there is a suicidal risk, it is must for you to restrict this patient in the medical facility at least up to 72 hours till your psychiatrist is reviewing the case in any station of PACES. Is this clear?
Yes.
Good. Very good. Now we are dealing with dementia. We are dealing with depression just in one line, just telling, I'm not going in details. Then recurrent history of falls. Before I'm going to recurrent history of falls and the dementia, this is linked with the dementia. First, let me talk about inability to take the food. Dr. Satinder, let me tell you one thing. NG tubing or PEG tubing is really not recommended and not backed by the evidence-based medicine to put in the dementia patients.
Okay.
They are having just forgetfulness. Sometimes they are putting food in their mouth and forgetting to take it inside. So we will not put it. Rather, we will refer this patient to SALT teams, speech and language therapist teams. Clear? We will not give the option of PEG tube insertion, might be or might be NG tubing. This should be very clear in the mind of all the candidates, because this is really one of the commonest mistake in the scenario of dementia. When the candidates are doing that in dementia, they are speaking that might be we are providing with the PEG tube, might be with the NG tube, might be with the NJ tube, and this is a big mistake. Not recommended in dementia.
Okay, when the surrogate is asking for this,
you will say no, not recommended. Finish.
What are the cases where it is recommended? Is it stroke?
Yes, of course, in the stroke and others it is recommended, but not in dementia.
Okay.
Now, I will be giving some red flags, some safety nutting to my surrogate, that please do not leave the dad unattended. He should not leave the home unattended, because might be he is forgetting way back to home. He should not cook, because if he is cooking, he will burn the food and will not remembering to close or to stop the stove. He should be taken care by active physiotherapy and by hygiene. Also, I am immediately talking to our occupational health therapist to look into this matter of frequent falls, and we will be providing him with the walking aids, and there should be no rugs at home. There should be nothing like that. There should be railing in the home. Also, it is very important exactly in which story the patient is living. If it's at the ground floor, it is different thing. If it's the first floor, you need to make the arrangement for that. Might be you're giving some railings, might be you're giving some lift. Clear?
Yes.
So let me summarize, because the time is limited in this scenario, that what I have to do: introduction, patient introduction, setting the rapport, setting the agenda, ultimately applying the ICE, then explaining that this disease is a process, degenerative process. What I mean by that is that there is aging of the different part of the brain leading to features. What are the features? The patient is unable to take care of himself on its own. He can have memory problem. He can have the problem in coping up with the calculations, and he is having problem in recognizing the people which are known to him, and he is sometimes having problem with bad depression and properly eating up. And this disease, third point, is progressive and is not curable, but we are over here to provide all the support to that. So in the support, number one, provide the depression, assess suicidal risk. If there is any risk, restrain this patient. Then there is problem with the food. So we are providing SALT teams, speech and language therapy team, and they will help the patient in eating the food and teach him how to take the food in. Third problem is with the falls, and we need to manage it by saying that I will be talking with occupational health therapist to see how we can provide him with walking aids, with rugless home, with some railing, some sports around the walls. Then dementia, we will be doing safety netting by saying that he should not cook, he should not go outside alone, and also he should need the proper appropriate care by the social teams. Clear?
Yes.
Ultimately, We will take a very short social history, that is financial support of the dad, smoking, alcohol, if there's any job, any previous job, and ultimately, I don't believe that the job is very important over there because he's already 85, but driving should be asked and must be stopped if he is still driving as per se. You have to refer this case, refer the son to different societies, sports group, because he is under stress, to join those groups and to know exactly what is dementia and to talk and to interact with the like-minded people. Also in the end, you have to provide with all the brochure, leaflet, some patient education website to read more about dementia. Clear?
Yes, yes. Okay.
Very good.
So Dr. Salman,
now there are some important points which depends upon the go with the flow like thing. We are not being provided whether this patient is competent or not. But yes, you can touch that topic of advanced directives, that whether your dad has written some advanced directives about the future life or future happening, and also whether he has assigned somebody as LPA, that is lasting power of attorney. Yes, Dr. Satinder.
Okay, so I actually got confused at few steps, one is the patient was having falls and it was a case of dementia. And when I was explaining to him about the whole situation, I was thinking about Parkinson's also, but there was nothing else which was giving the information regarding Parkinson's.
We will stick to our scenario, finish.
Okay, so, and when I was discussing about the treatment options, I was not able to think about any of.
There is a drug called donepezil, amantadine sometime they are giving. Yes. But yes, I am a junior doctor. I will never say in the station, communication station, that I will give this medication. Say that, yes, sir, there are some medication for this condition. But of course, treating team is in a good position to decide about that. And if there's any option about that, we will immediately communicate with you.
Okay.
We will not go outside our scenario because they are not giving us a scenario over there that you should start donepezil, might be amantadine, might be.
Mm-hmm. So what shall we say in the treatment, that the treatment will be decided by the treating team, right?
We will not say anything. If he is asking, then we will say that your concern is valid. If they are starting any such medication, we will let you know, because these medications are just slowing down the process. Still, it is going on and they are not very effective.
Mm-hmm. Okay.
Okay. Anybody wants to ask any questions, queries, any problems? Dr. Joel, please unmute.
Hello, sir.
Yes, hello.
Yeah, so should we ask the son whether he is the next of the kin at the starting, or it's not required?
No need. Why? Because if you're asking that whether you are next of the kin or not, what will happen? If he's saying no, what you will do?
Okay.
You will stop your scenario?
No, sir.
So you're allowed to speak to the immediate family member.
So we tell that we have permission to speak because the patient is advanced dementia. We don't know
because
if
we have not taken the permission, or might be they have taken the permission. We will not say because we are not knowing exactly whether the patient is competent or not.
Yes, sir. Okay. Okay, sir. Thank you.
Dr. Mo, please unmute.
Yes, sir. I wanted to understand what our plan of management for this patient of advanced dementia. This future aspect which written in the task of the candidate. This patient
has
already
discussed multiple things.
lost memory, and he cannot take food, and the driving is risky. So this patient should be should be admitted to hospital or at home, and no one leave him alone. This is what I
No,
understand for
no,
dementia.
no.
You will leave him to
We
go
will
home and
be
walk in
first
the street.
asking who is taking care of the dad at home. How is the social support? If he can provide the social support through might be siblings, might be some relatives, that's a good thing. If he is unable to provide the social support to the dad, then our social teams will decide how they will keep the check on the patient and how they will take care of the dad. Because this is not a condition to get admitted in the hospital. It's not a acute condition. Okay, it's an ongoing condition, and basically he need a nursing care. So the treating team will decide, sorry, the social team will decide whether they are providing this nursing care at the home, or or they are shifting him in the hospital. Sorry.
This patient should
I'm so
not be
sorry.
alone.
Let me complete. So
Yes.
the social team will decide whether they are providing this nursing care at the home or shifting him in the nursing home. Yes, now ask.
Yes, he will be only admitted to the hospital if there is any suicidal attempt. Otherwise,
of course, or any active medical issue.
Yes, and they should not be alone. This patient should be with anyone, either from the family members or nursing staff.
Amazing, amazing, amazing.
Okay, okay. Thank you, thank you, thank you.
Dr. Sayyada, please unmute.
Assalamu alaikum, Dr. Salma.
Wa alaikum assalam.
Is there any point to give thiamine or think of where next course of cough in this case?
We will not think. Even if the diagnosis is that, we have to stick to our task. We are not going out of our task. In the station 4, this is not something to take the history or examine the patient or make the differentials. We have to just communicate with the patient according to the task given. Dr. Sayyada, is it clear?
Thank you very much.
Welcome, welcome, welcome. Dr. Faisal, please unmute.
So thank you very much for giving me time.
Yes.
So should we ask the son to get written the legal power of attorney if it's not there at the end
No.
of?
We will simply say anybody your dad has assigned as LPA. If yes, good. If no, if the dad is getting competent, they can discuss this issue. Because competency is something which is not fixed. And this is a question of the examiner. Competency depends upon the current situation. Say, for example, right now, the dad is not in senses because of memory deterioration. Right now, he is not competent. Might be he is regaining the consciousness. Might be his memory is fluctuating to betterment in coming day, might be or two. So you can ask at that time if he's getting competent, that whether you want somebody as LPA or you want to assign as any advanced directives. Clear?
Yes.
So, important point. Competency is not absolute term. Right now, a person is under influence of might be alcohol. He's not competent. Might be he's getting competent after a couple of hours. Similarly, dementia is fluctuating, is having a fluctuating course. Right now, dad is not in senses. He's not recognizing anybody. Might be after a day, he is again recognizing somebody and he is getting competent. Then we can talk about these issues. And who will decide whether the patient is competent or not? Psychiatry team will decide. Dr. Karishma, please unmute.
Good afternoon, sir.
Good afternoon.
After a long time, thank you. Thank you so much.
Welcome.
Sir, in the safety netting, we can give any regular vaccination for these patients or protection of the bone, especially in ladies, if this patient is a lady?
You're right medically, but we are not going out of a scenario. We are usually not prescribing any medication because you are talking like a SH or might be reg over there in the scenario. Yes, if some medication is written over there and they are saying to you that do that procedure, then you will do. Otherwise, by default, we are not prescribing any medication.
Regarding vaccinations, sir, if they are living in nursing home, then?
This is the other issue then. This is the other topic then.
Yeah. Okay. Thank you,
Good.
sir.
Welcome. Dr. Javeria, please unmute. Dr. Javeria, do you have any question? Dr. Yasmin, please unmute.
Hello, Assalamualaikum, Dr. Salman.
Walaikum salam.
I would like to ask, do we need to put in the safe netting about like we need to ensure that his fluids is adequate, nutrition, to avoid constipation or pain, to avoid him from tipping into delirium?
You are very right. And that's why we are referring this case to our social team. And what they have to do, they have to take into account all these parameters, not only hygiene, but also general care of the patient, including falls. And that SALT team will take care of the patient nutrition status and the patient general well-being.
Okay, thank you, doctor.
Welcome.
Doctor, I'm here. Assalamu alaikum.
Walaikum assalam.
This is Dr. Javeria.
Yes, go ahead, please.
Okay. Thank you, doctor, for such a good session. In fact, doctor, I have two queries. One is that regarding the social history of the patient. Should we explore the social history of the patient, because patient representing with the recurrent fall, like is patient is taking any alcohol, is smoking, something like that, or any drug history, which would be the cause of a fall?
You are right. That I was mentioning in the end, that it is important to touch the social history. In the social history, what we are mostly asking, smoking, alcohol, any specific addiction or drugs, any social sport, financial sport, this is what we are asking.
Okay. And another question regarding the fall as well, dementia as well, like we should know the capacity of the patient, how much he is competent to, at least he can read and write, or sometimes patients for the dementia patient, they couldn't able to even find proper words, or they couldn't able to read or write. So it depends on like how we can, manage those patients, like labeling things or something like that. So important about that. Should we explain to the carer about like how they can do that in such a way?
Remember, you have only 10 minutes with this case. And there are multiple things to touch. You have not been given any free time, or might be 1 hour to talk about everything. You should just touch those topics. And that's why in the touching, we are mentioning the SALT teams to communicate with the patient. We are mentioning social teams to look into account the patient hygiene, patient walking problems, and others. So we have to touch it. But yes, if you are getting time, then of course you can incorporate it in your narration. But again, the problem is the time.
Time, yes. Okay, I understand. Thank you, sir. And one more question regarding the next of kin question. One of the doctors has asked to, like my point is that, like if patient is competent enough, then we can ask about the next of kin. But patient is not competent now. Patient is, lost sensorium, or patient is not in a condition that he can.
Patient is competent. Say, for example, patient is competent, and you are talking with the son.
Yes.
And you are talking about whether you are next of the kin or not.
Yes.
As if he is saying, I am not next of the kin, then what you will do?
Yes, that's my point, doctor. What to do? Because there are in certain scenarios, they are asking about the confidentiality.
I am telling you,
like
I'm telling you the
like,
best. Yes. The better thing is that you will start your scenario like that. Say, for example, you're talking with the son. Hello, sir. Good morning. My name is Dr. S. I'm Dr. again today. Am I speaking to Mr. X, the son of Mr. Y? Yes. Sir, we are over here to discuss about your dad's health condition with you. And I have already taken the permission of your dad to talk with you about his health condition.
Okay,
Finish.
fine. Okay, got it. So,
and they have written the scenario that we have already taken permission from the patient when they're giving you any such scenario.
Okay, okay. Yeah, that's why I'm confusing in some scenarios whether we need to ask or not to ask actually. Okay, thank you, sir. So nice of you. Thank you.
Make sure that you have taken the permission from the patient to speak to third party.
And we need to just mention it actually initially.
Yes, yes. Okay, thank you so much, all the candidates, for your participations. Welcome, Dr. Javeria, your questions, your queries, and your time. With this, we are concluding our session. Have a good night and goodbye.